What's going on, everybody? My name is Adel, sports neurologist at the UCLA BrainSPORT program, and this is the UCLA BrainSPORT Podcast. Today, very special guest, Lorella Batteli, assistant professor of neurology at Harvard and researcher at the Italian Institute of Technology.
Correct.
Yes.
Excellent. Glad to be here.
Yeah, so this was a big issue, me introducing you. It was a little bit complicated, but I got it.
You did a good job.
All right, so today, you're here to talk about non-invasive neuromodulation.
Yes.
Which I think it's really cool because I really do believe that that's sort of the direction that medicine is headed in, right? It's like, especially all these potential adverse side effects of medications, especially in the neurological context. I think neuromodulation is like such a great alternative to that. You know, it has minimal side effects, and we can talk about those. But then I think a lot of people are interested in it.
Yeah, no, that's great. It's extremely interesting and pretty exciting because we are really making some good progress, and considering that for a lot of diseases and disturbances there is no cure and treatment, finding alternative treatment and cures is actually very desirable. So pretty exciting. I really come from TMS, transcranial magnetic stimulation, so my background is mostly on that, and I'm a basic research scientist. But I got interested in neuromodulatory effect of transcranial electrical stimulation like about a little over 10 years ago. And, you know, was a little skeptical, but I said, why don't we give it a try in the lab? And so we did, and so far it's worked great. So we have very interesting results, pretty exciting. So we continue to use it.
Yeah, so I want to start very broad with like, what is neuromodulation, especially like non-invasive neuromodulation. Then I want to talk about sort of how it might work in disease states, and then I want to move on to how it can potentially help non-disease states, help people enhance performance. You know, very interestingly, due to the actual reality of this helping, you know, elite athletes and different things like that, this whole ethical conversation of neurodoping has come up, right? Which I know you know, the World Drug Federation for the Olympics is considering. But let's just start with a good definition as to what non-invasive neuromodulation is.
Yeah, so I believe you have already talked about TMS in this podcast. So differently from that, transcranial electrical stimulation is just a small amount of current that we deliver to the brain. So it reaches the cortical tissue underlining the electrodes that are positioned on the scalp, and you deliver this small amount of electrical stimulation, and what you do, you have this neuromodulatory effect. So basically, you're not actually changing action potentials like TMS will do, but you're actually doing a modulation on the membrane potential. So you are actually interfering with the already ongoing activity, electrical activity in the brain. So that's why we say neuromodulation. So it can come in different flavors. So the most well-known is TDCS, transcranial direct current stimulation. That can be delivered either in a nodal modality or cathodal modality. So a nodal typically has an effect of making the cortex more excitable, so the response is excitation of the cortex, whereas cathodal is inhibitory effect. But then you also have TACS, transcranial alternating current stimulation, and also TRNS, transcranial random noise stimulation. So you really can control in these latter two cases the frequency at which you can stimulate the cortex. So you really are trying to go and interfere in a positive way with the ongoing oscillatory activity of the brain and the cortex.
So that would be dependent. You're trying to interfere with the oscillatory component of the brain, and that would just be based off of the disease state, right?
So, under healthy, normal circumstances, we still have this oscillatory ongoing activity in the brain that changes depending on the phase in which we are. So if we are resting, for instance, typically you are in an alpha phase, resting state. So if you're resting with your eyes closed, you will be in alpha, which is a frequency between 8 and 12 hertz of activity, of frequency. Whereas depending on different phases and different part of the cortex where you are recording, for instance, with the EEG, you can see that depending on what you're doing, if you are in an active state, different oscillatory activity will be present. So alpha, beta, theta, gamma, and so on and so forth. As you were mentioning disease, what happens in disease is that this might be disrupted, not working properly, and the cause might be a psychiatric disturbance or also after a stroke or after a traumatic brain injury and so forth. So the idea is, can we use these neuromodulatory techniques to recover these functions and at the same time reestablish somehow some good oscillatory activity in the brain?
So outside of just providing that appropriate oscillatory activity in the brain, what are some anatomical changes that might be happening secondary to the stimulation? You know, what I've seen, it's potentially this can promote neuroplasticity, right? Dendrite growth, axonal pruning, right? Which are sort of markers indicative of actual neuroplasticity.
Yeah, exactly. So that gets a little tricky because as a result of a lesion, your cortical activity might change. And also, as you said, we all have different anatomy and distribution of the neurons, and they're also distributed between layers. So what will work in a healthy brain might not work in a diseased brain. So you really need to understand exactly what you're doing, right, how the current is going to distribute in the brain of a healthy brain and in the brain of a diseased brain. So you can do some modeling and do some current distribution modeling to see what happens in the case you decide to stimulate at that precise frequency or at different frequency. And so we can model that.
And I think that brings up the changes that occur secondary to electrical stimulation in children could be like completely different, right? Because that's a developing brain versus already a developed brain.
Yeah, besides obviously the ethical issues in that case.
Oh yeah, I forgot about that. I'm just kidding.
Very important. Well, we may say that direct current stimulation is pretty safe, and there haven't been any big episodes of inducing, for instance, seizures or serious side effects like that, which you might potentially get with TMS, for instance. So in that sense, it's considered a very safe technique.
Right.
And in some conditions, the patient doesn't even feel it. So I think it's potentially a good tool to be used in developmental age too.
Yeah, nice. So let's talk about what you've been doing in your research with, this kind of transcranial electrical stimulation. What have you been up to?
Yeah, so we got interested in TRNS, transcranial random noise stimulation, and the reason is that it seems to really put the brain in an optimal state to be plastic and to learn. So we're interested in learning, and particularly in visual learning and attentional functions that can be severely altered after stroke. So we have noticed that if you do TRNS training coupled with behavioral training, so you do TRNS stimulation and then you couple it with behavioral training for just 4 days, and then you look at the brain of subjects who did this training. So you look at the brain at baseline, and then you look at the brain again using functional magnetic resonance imaging at rest. Immediately after the end of training, we have noticed that network in the brain change the way they talk to each other. So we change functional connectivity. Okay. And on top of that, that change actually correlates with changes in behavior. So people that are being stimulated on specific part of the brains that are involved in attention show this quick improvement compared to sham stimulation or other areas when the other areas are being stimulated. So the idea here is that not only is important to identify the proper area to stimulate, the crucial part of the brain that you need to stimulate, so the node of the network, but also couple that with a specific behavior. Okay, so we can do this in attention. But we've done this in vision too. So for instance, if you have a stroke to the back part of your brain and you get a lesion to the occipital areas of your brain, you can become cortically blind, which means that your eyes can see, but your brain can no longer interpret the visual information that comes through the eyes.
Right.
You can get partial cortical blindness, so one half of the field is blind, the other half works fine. So we are now working on a clinical protocol precisely to help these kind of patients recover their blindness in the bedside.
Right.
So,
so you're doing cortical blindness. You're looking at cortical blindness, or are you looking at visual field deficits?
Both.
You're
so
looking
it's
at both. Okay.
pretty much the same thing. It's called hemianopia, and in some cases also has some very interesting effects, like effectively the patient is blind in the portion of the visual field, but then if you do specific testing, you can see that they behave and they respond above chance, which means something is being processed by the vision. The subject is not aware of it.
Right.
So it's really interesting. But yes, what we're trying to do is really trying to reduce the size of the blind portion of the visual field where the deficit is. And we do this coupling behavioral training with non-invasive brain stimulation. And then we do all sorts of imaging to look at the brain to see what has changed before and after training.
Right. So just to summarize, you took patients that had suffered strokes, right? So a potential form of brain injury, right?
Yes.
To the occipital lobe.
Yes.
Right. The occipital lobe is involved in obviously visual processing, right? So, you see what you see through your eyes, and it transfers through your retina via a bunch of different processes. It gets to your occipital lobe, and your brain processes what it sees in the occipital lobe, and then based off of that processing, which is not just relegated to occipital lobe, it's involves a lot of other processes. But then that sort of visual processing occurs there, and then you sort of form your actions based off of that processing.
Correct.
People that have strokes or any sort of brain injury in the occipital lobe see what they see, but they can't process it, right? So
Right.
virtually they don't see anything, right?
Yeah, and keep in mind that there isn't much for this kind of patients out there for rehabilitation.
Yeah.
So there are some compensatory techniques that are being taught, but in the end, the blind spot remains. So I can teach you to compensate by moving your eyes, and then you move the beds, everything in the good field for you, but your blind spot is still there.
Right.
So you're still going to have trouble, for instance, driving. You're still going to have trouble navigating the environment and so forth.
Yeah.
So, but so we are trying to help these people, for instance.
So then you took these people and then you did transcranial random noise stimulation, I'm assuming to the occipital lobe, right? AKA
Correct.
to the back of the head.
Yeah.
And then you also sort of did that alongside what the standard of care is, right? To see if it
Correct.
could supplement their recovery with the standard of care.
Yeah, exactly. So, exactly so.
So it's like therapy or something, right?
Yeah, actually, some of these subjects are considered chronic. So it's more than 6 months after the stroke. So the doctor will say you're now stable. There is no more room for improvement, probably. So they just learn to cope with it. So standard of care in a way is gone at that point, and so but then they can come to us and we can try to help them. Importantly, it's a clinical trial, so everything has to be done the proper way. So we have a sham control, so some subjects receive active stimulation, some other sham stimulation, and so forth. This has to be kept in mind because as I was looking at studies in sport or in brain enhancement and so forth, many studies actually are missing important parts, like they're missing sham controls, they're missing, so it's hard to judge the literature.
Right. So back to sort of this brain injury model, right, that you're working with. What have you found so far for the patients that you do this stuff with?
Yeah, so it was really surprising and great to see, exciting. So like in 2019, 2-3 years ago, we published this paper where we show that, so typically these patients can do just visual training. So, and they do this, for instance, in collaboration with my collaborator at the University of Rochester. They train for many months on a daily basis with this visual stimuli, the same that we use. And it takes many months for recovery to happen. And so basically, like for some of them, even up to 12 months to be able to see a significant difference in improvement in performance in this task.
Now, I'm sorry to interrupt you, but is this standard of care, this visual training thing, or is this something?
This is just lab design visual training.
Okay.
So it's called visual psychophysics. So these are adaptive stimuli that we use for the patients, and the stimulus will adapt to the patient's ability. So if you perform well, the system will make the task more difficult.
Right.
As you perform worse, then it will make it easier.
Okay.
So it's adapted
Right.
to the individual ability, sort of like precision medicine of vision in a way.
Yeah.
And whereas those few patients that we did with this TRNS stimulation, they improved significantly in 2 weeks training as opposed to months and months. So we were like, wow, this is exciting.
Okay.
And so we decided to continue to do that. We got funding to do that. And so now we have an active clinical trial in Boston to test more patients on this. And we will be testing chronic patients, so those that have been in that situation for more than 6 months. And then we will also be testing acute patients, so those who had the stroke no more than 6 months before.
Right.
So because we think that probably plasticity in the 2 conditions will be different, probably the acute patient will be more responding relative to the chronic patients, but we'll see. So
what's the magnitude of response that you saw in the patients that you've already done? Like how much there's improvement, but like how much?
Yeah, so they go from 50% performance, which is chance level.
Right.
They're responding, it's called 2 alternative force of choice procedure. So you ask them whether some motion is moving to the left or to the right. So they go from chance level to up to 75%, even 85%. So improvement.
So walk me through what you're doing for, like, how you're testing them, right? So this alternate thing.
Yeah.
So you're having.
Just
explain it.
This is very important, and I'll try to be as simple as possible.
Yeah.
So you have what is called an eye tracker. So you have to make sure these people don't move their eyes.
Mm-hmm.
Okay. Otherwise, they will do compensatory stuff, as I said before. Okay. They will compensate for it.
Okay.
So you really want them to fixate on the center.
Okay.
And then what you do, you try to position the training task on the border within the blind field. So you of course need a visual perimetry that will tell you where the blind field is.
Right.
Okay, so like when you go to the eye doctor and will want you to measure your visual field.
Yeah.
Okay. And then once you determine where the blind spot is, you put the stimulus in there. And of course, it's very frustrating because think about that. You are fixating and they're telling you to do something where you can't do anything.
Right.
And you go like, I just want to move my eyes there.
Right.
Every time you move your eyes there, abort mission.
Okay.
So the trial starts over
You're
again.
You're disqualified.
Okay. So it's just like, it's very frustrating.
Yeah.
But once they get it, so they have no choice.
Right.
The camera is monitoring their eyes, so they can't move their eyes. And then they start training in there. What happens is that at the first session, they don't report seeing anything, and they go like, why are you testing me in there? But then they sometimes start to say, I see a sliver of something. Something is moving down there to the left, at the bottom left or at the bottom right.
And it's in the same exact place that it was before.
Yes. So you keep the same position every day. They come for 10 days, so Monday through Friday, and then again Monday through Friday the following week.
Okay.
But already by the 3rd session, and just telling you because this week we had a patient and that's what she was saying, was that by the 3rd session she was saying, I have a sense of motion. I have something. I can see something in there. Maybe you just moved the stimulus, but we didn't.
Okay.
So it's no magic. It's simply we're just
That is magic. You realize that, right?
Well,
what you're
I
doing
don't want
is
people
magic.
to think that. It takes a lot to get there.
No, I know. And it's in conjunction with this sort of visual therapy that you're doing,
Yeah,
right?
and we don't even know. Yeah, exactly. So, and note that this subject, we don't know whether it's a sham or an active stimulation condition. But what we know is that the training is also working in itself, probably.
Sure. So the sham is also getting the vision therapy, obviously, right?
Yes, exactly.
Right,
so it's everybody's getting something.
Right.
Except that some will be getting active stimulation and some will not, by design, obviously. But so it might be just a particularly good patient.
Right.
But at the same time, the patient by herself, she's just reporting, I think you are probably making things too easy for me, maybe.
Right.
But then when you look at the data, so the patient can say what they want, but what you need to have is an objective measure, okay? So this is not a questionnaire. We do that too. So we ask them before the training, and then at the end of our training therapy, we have questionnaires again. But what we want to have is an objective measure.
Right.
So, and in that case, the objective measure is the performance in the task. They don't know how they're doing.
Right.
So, but we see the improvement.
So what performance is that you're, I thought that was the performance, is that thing where they're noting improvement. So that's your objective measure.
That's the objective measure, exactly. And then importantly, because you may say, she's getting better in motion detection task in that portion of the visual field.
Right.
Great. Does it help in everyday's life?
Oh, functionality.
Exactly.
Yeah.
So what you really want to do, the ideal scenario is to be able to say that the improvement you're getting transfers to other functions.
Right.
And so you do other tasks on which you did not do any training.
Yeah.
So you look for transfer on other visual tasks.
Right.
And then you test them on other things like functional MRI to
Yeah.
see whether functional connectivity or other parameters have changed. And you also do EEG and so on and so forth, and the questionnaires too.
Have you done the more objective measures when it comes to functional MRI and EEGs?
We are collecting data
You're
right
collecting
now,
the data?
so we just started.
Okay.
So I can't really tell you much.
No, what you've
But
told me so far is like really interesting. Though. That's
Yeah,
awesome.
no, and there are only few studies out there. And again, my collaborator at the University of Rochester have done most of it, and they have very nice results. And their latest result, which is I find extremely interesting, is that they've been just testing acute patients. And
Acute stroke patients.
yes, acute stroke patients. Sorry. And what they see is this quick improvement, which is faster than they see in stroke chronic patients.
Right.
So,
Okay. So just to summarize, you're taking patients cortically blind secondary to a brain injury, aka a stroke in the occipital lobe, right? You're doing vision therapy along with transcranial random noise stimulation, right?
Correct.
And you're actually seeing an improvement in their cortical blindness of 70 to 80%, or did you say 75 to 80%?
No.
Or their performance.
30%
20 to 30%
in their performance,
in their performance on this sort of visual testing, the objective visual testing that you're doing.
Yeah, and they have a built-in control.
Right.
The good side, you can test a good field, and then they perform normally in there.
Right.
So you have a control there, which is really nice.
Excellent. And then how you believe that this is happening, this recovery is happening, is secondary potentially to the neuroplasticity that you're prompting with this transcranial random noise stimulation.
Yeah. And actually, this is a very interesting question that makes me do the point of the second part of the work we are doing. This is instead a collaboration with Children's Hospital in Boston.
Mm-hmm.
We are collaborating with neuroscientists who work with mice, and they're actually going to go and make a mouse model of the stroke our patients get. And they're going to see what parts of the brain are actually helping the recovery.
Okay.
So the lesion is in one specific place. The question is, are areas around there trying to compensate for the deficit? Or are subcortical areas, such as the thalamus, is the thalamus helping the recovery? So all these questions we can answer with what we do. Not even fMRI will be able to tell us, but then we are working with neuroscientists who are doing the mouse model of what we're doing. So we will be able to look at the mechanism of these workings.
So I know that it's an issue that I've come across just reading, prepping for this, was that, TDCS and a lot of these transcranial electrical stimulation modalities remain relatively cortical, meaning that they don't really shoot too deep into the brain. But that's not to say that if you hit a neural circuit in the cortex, that's not going to transfer via that neural circuitry into the deeper structures.
Exactly. In fact, this was the general belief until a few years ago, but now that we have more imaging studies, like we do too, we can really see that if you hit a proper node on the cortex and it's part of a specific network, it can either be the dorsal attention network in the case of attention studies that we do, or it can be the default mode network in other cases and so forth. So the well-known networks in the brain for different cognitive functions, you really see the difference within the network.
Yeah.
So in our case with TRNS, and this is a study done by people in my lab, we have seen that indeed these changes in functional connectivity is between areas in the brain that are also distal from the side of stimulation, and even some deeper structure too might have an effect.
Yeah.
So
And I don't think that's only with transcranial electrical current stimulation. I've seen it with TMS where, you know, in depression, they stimulate the prefrontal cortex, and then they also note, like, you know, changes in activity in a completely separate part of the brain. I think it was like the subcingulate gyrus or something like that. I don't know. I don't remember it now, but nonetheless, it's like clearly there's like changes, you know what I mean, in other parts of the brain secondary to likely tracking along that neural circuitry.
Yeah, it's super interesting. And as I was saying at the beginning, I come from TMS, and so I have done TMS in the past because first I got interested into it because if you have a stroke, you have these large lesions, so you can make hypotheses on this particular part of the brain is causally related to that specific task, but you can't really say that entirely because you have these big lesions. With TMS, you can be more precise and try to stimulate just the crucial portion you think is important and do this causal study. And so you can kind of mimic a patient's behavior, in a healthy subject temporarily. So you can actually deliver 1 hertz low frequency TMS to inhibit that cortex and then see how they behave afterwards. They're called offline studies. And when you do that in the fMRI, so if you inhibit the cortex and then you put subjects in the scanner, what you see is that there is an hypoactivity in the areas that you've been stimulating. But interestingly enough, you see these distal effects that happens late, They don't happen immediately. So 60 minutes from the end of the stimulation, you see these nice responses that are probably compensatory in more anterior portions of the brain, even if you have been stimulated in more posterior portions of the brain, And you not only see it in the hemisphere you have stimulated, but you also see it on the contralateral side where you did not stimulate.
Very interesting.
So there is a global response.
Yeah, and then what I've seen is the actual neuroplastic changes or any sort of changes relating to stimulation are likely going to be seen best with repetitive stimulation, right? Rather than just like one-off sort of one session.
But that really depends on your experimental paradigm. We are interested in repetitive stimulation offline just because we are also interested in a long-term effect. So neuroplasticity keeps coming back, So when I was doing low-frequency RTMS in stroke patients, the idea was the following. If you have a lesion on one side, you kind of lose the balance between homologous areas in the two hemispheres. So, for instance, in the case of attention, if you have a lesion on the right side, the other side might become hyperactive and sort of preventing recovery from the bedside. So the idea here is, can we try to inhibit the hyperactive side, sort of pushing the bedside to work better? So we did that with TMS. So you do repetitive TMS offline, and then you measure behavior. You measure behavior before and after in the patients, and you see this nice recovery of attentional functions on the side contralateral to the lesion, which is how typically you will find the deficit. But the interesting part again here that I would like to underline is that the effect that you see, the beneficial effect that you see, is not immediately at the end of the stimulation, but you see it 30 minutes later. Then you see these peaks all of a sudden. So what is really important is really do multiple testing to see how neuroplasticity is developing, And what you don't find now, you might find 30 minutes later. So an hour later.
And you're trying to underline that, especially because you feel that that a lot of studies will do it and
Yes.
then test neuroplasticity like right
Yes,
afterwards.
Very true.
Yeah.
So a lot of studies, probably a lot of data sitting in some scientist drawer.
Right.
Didn't publish them because it was a null result.
Right.
But sometimes, yes, you have to continue look. So
Right.
we now have some data that are not published, but a postdoc in my lab was working on a working memory training, and then immediately at the end of the training, there wasn't such a strong effect, coupled with TRNS again. Then she asked these subjects to come back a month later and 3 months later, and there was this buildup of an effect.
Right.
So she could see something 1 month later and even 3 months later.
Right.
So
Very interesting.
it's very interesting.
Very
Important to know. So there is some sort of cumulative effect
Yeah.
that is out there,
Yeah.
probably.
Now, like, let's transition to, because at
Back
Brain,
to TDCS.
yeah, no, to a different disease state, I think, because at BrainSPORT, like, certainly we're interested in all sorts of brain injury, but we focus on traumatic brain injury,
Of
you know,
course.
and traumatic brain injury rehabilitation. I think it's like, neuroplasticity is like a huge component of that, right? Do you feel that this can be applied in other disease states too, like TBI?
Yeah, so well, first of all, my impression is that at least what is in the literature now, TMS has been used more often than direct current stimulation
Yeah.
in case of even moderate TBI and so forth.
Mhm.
So, but that said, and also there are a lot of studies that are not properly run. Like, for instance, there is no sham control.
Right.
So if you get an improvement with just brain stimulation, it can be that maybe you take a hot bath and you get an improvement.
Right.
So you don't know, right? So
right.
you need a control condition.
Right.
So many of these studies don't have that, but when they do, they see some nice improvement. I know that, for instance, after these traumatic brain injuries, they might suffer from migraine headaches or having some cognitive problems, especially with memory and so forth.
Right.
And some of these non-invasive brain stimulation treatments seems to help. Particularly, as I said, with TMS, but there are also some anodal TDCS studies out there that are kind of interesting. So there seems to be some promising help out there. So
yeah, with mild traumatic brain injury and concussions, it gets really difficult because by definition there's no sort of structural injury.
Exactly.
Right? In concussion and
go?
mild traumatic brain injury, unless you like do some of these non-normal, studies that don't have normalized data that are strictly research-based, like DTI or like functional MRI imaging, then potentially you can see some abnormalities, right? But like, I think a lot of the non-invasive neuromodulation that you're doing is based off of being able to find a focus sort of lesion. Right?
Yeah, exactly. So what marker do you use in the case of a TBI where there is no actual issue in the brain if you just look at the imaging?
So like a TBI, like moderate to severe, you'll see some structural damage on the brain, right? So potentially you could correlate that with clinical symptoms,
right,
and then maybe be able to dictate your neuromodulatory sort of technique based off of that, right?
Yeah.
But like for mild, like for concussion, it's really difficult because what we say it's usually a strictly functional issue, right? Meaning no structural injury. Where do we put this thing? Where do we put TDCS? Where do we put TMS? It becomes really difficult.
It does.
Certainly you might be able to map something out with a functional MRI, but
yeah, so yeah, it's complicated, and especially it becomes some sort of it's not one unique treatment to treat everything.
Right.
And I kind of do not like that.
Right.
As much as I don't think it's appropriate to do it yourself type of stimulation. So
Have you found that a lot with TDCS? So what I've heard about TDCS, it's like, or some of this transcranial electrical stimulation, is that it's so accessible to like anyone that really wants to do it because it's really not that complex in terms of the technicality of developing the actual thing yourself.
Yeah, there is a flourishing of all sorts of things available online, and my favorite one, I will not say the name of the of the system, but
Say it.
it was Halo.
Oh, I've heard of Halo.
Yeah, and so they were saying
Halo neuroscience, right?
Something like that. So if I remember correctly, but it was saying it can improve your visual functions, and the picture was showing this, lady with these 2 electrodes in the front of her head.
Right.
So clearly not the visual cortex.
Right.
But it was just like, just the premises were just wrong.
Right. From like a mapping perspective and where you're stimulating.
Yeah.
All sorts of stuff, probably.
Yeah, exactly. And just in general, I would like to point out that we really think carefully for our experimental protocols. So we really think how we want to change that function. How do we measure that functions? And everything works around thresholds. So there are things that your auditory system can hear and things that you cannot hear. So goes for your visual system. So goes for if I'm putting pressure on your skin, you will start feeling the pain only after a certain amount of pressure and not before. So everything is a threshold, okay?
Right.
And so what is a specific threshold for you might not be the same for me. So, and if you want to challenge my system, you need to put me at my threshold because your threshold might be too easy for me, okay? So this applies very well in vision. So if I'm looking at something that is way too easy for me, you can put anything you want on my head, but I bet you won't get anything out of this experiment because you're not challenging the system, okay?
Yeah.
So that said, so if you think that you can really lay down, rest, and getting your stimulation like going to the spa, I don't think it's going to do much to you. You better take a hot bath, as I was saying before, right? It's more relaxing.
Yeah.
But if you instead couple that brain stimulation, whatever you're doing with a proper behavior, then probably you will get the best results. And how can you do that? I don't think you can do that at home out of your own initiative, right?
Yeah.
So
I gotta connect you with Kevin Pickart. Shout out Kevin Pickart. I think I shout him out like almost every episode, but he's doing TMS work. He just got his grant funded by the DoD, I think.
Good for him.
Forgive me if I'm mistaken, Kevin, but he just got his grant funded by the DoD, and he's going to be looking at TMS specifically, I believe in PTSD patients, right? And, he says the same thing, that what he's found is that, TMS, he's seen patients get TMS while like laying back and watching Netflix, right? Whereas he's like, no, that's really not the efficacious way of doing it. You have to do it with some sort of what he recommends is active exposure therapy, right? So that's sort of the therapy, the standard therapy for PTSD, right? Is like sort of this exposure therapy. And in that context, you bring out that circuit, right? And then you do TMS so that circuit's brought out so that then you can address it more fully with TMS.
Exactly. And in fact, this brings to the state-dependent effect topic, which is really important, I think.
Yeah.
It really makes a difference. We did a very, very simple study in our lab about 3-4 years ago where, so if I give you a single pulse of TMS or multiple pulses of TMS, again, on your occipital cortex, you might be perceiving visual phosphines, which are these visual illusions in your visual field, like a bright light or very quick, okay?
Which is induced by the stimulation,
exactly,
right?
Induced by the stimulation on your occipital cortex. So, and I can measure the threshold to phosphine, so the intensity of the stimulation of the machine that I need to crank up or down in order for you to be able to see these visual phosphines. If I prime your cortex before I do this procedure with TRNS, then I measure your visual phosphines again afterwards, you will have a much lower threshold to visual phosphines, which means that it will be much easier for you to see phosphines when I give you a pulse of TMS.
Okay.
So I kind of prime your cortex to respond better to my stimulation.
Yeah.
So in a way, this is telling us that if you can sort of prime the cortex and put it in a state that is optimal to respond to the subsequent manipulation, then maybe your neuromodulatory effect might be stronger.
Yeah.
Might be better.
Very interesting.
Yeah.
Have you looked at focus ultrasound?
I not personally, but I of course know of it, and it's also pretty exciting. It's still kind of in its infancy, so I'm sitting back,
waiting to see what happens. No,
but it sounds very interesting.
Yeah, I've heard a big positive about focus ultrasound is that you can really shoot in deep into the deeper structures.
Yeah, exactly. So that's the what seems to be the big difference from other, using the surface electrodes and looking at the stimulation differently. But I'm pretty happy with this network effect that we get, and until I'm getting, behavioral effects, I'm pretty happy about it.
Right.
But definitely true. For instance, if you are able to reach subcortical structures, more hippocampal regions, or working with, improving memory or doing things like that, and or for instance. Really, areas that can help you control Parkinson's disease or something. And so alternative treatment to deep brain stimulation, for instance, that would be interesting. So
yeah, I know here at UCLA there was a study going on looking at focus ultrasound in the thalamus, right? So the thalamus is like this really deep structure that's definitely not in the cortex. It's a subcortical structure, and it's involved with sort of awakeness.
A lot of things.
It's involved with a lot of things, but it's also involved in like staying awake, right? Because your awakeness, actually, that circuit goes through the thalamus, goes out to the rest of the brain. And they were doing focus ultrasound for minimally conscious patients in traumatic brain injury to the thalamus. I don't know the results of that study. I should probably have them on, but no, it's like really interesting. And like that's the positive focus ultrasound, right? It's like you can actually get to the thalamus. You can map and hit the thalamus.
Yeah, no, very true. And anything that can help understand where those patients are with their awareness. I mean, it's could be super helpful and interesting.
Yeah.
But so there are interesting groups in Germany. They're doing a lot of focus ultrasound, and other groups around the world. So super interesting.
So we'll wait and see.
Yeah,
see what happens with focus. I'll just sit back, relax,
take your bath, and
take your papers out of the drawers.
Publish them.
Publish them. Yeah. So one interesting thing I think is this sort of neuroplastic component of transcranial magnetic or neuromodulation in general, right? And why I think it's so important. It's like, from a clinical perspective, how that would translate to sort of the neuroplastic components of neuromodulation. If you can enhance neuroplasticity in brain injury with neuromodulation, the way that I think about it is, when I have a patient that's like, 14 years old, 6 years old, that has any sort of brain injury, right? We see traumatic brain injury, so they'll come in traumatic brain injury, right? Moderate to severe even, right? So it's not just like, run-of-the-mill mild traumatic brain injury.
Yeah.
It's more severe. We can see them like a year or two later, and their recovery is astounding. Like
You mean spontaneous recovery?
Yeah. So spontaneous recovery, where I'm sure they're doing therapy.
Assisted,
they're doing the standard of care therapy, right? But like when I have those same patients that are 60 something years old, right, either having suffered a traumatic brain injury or a stroke, that same amount of time period with that same standard of care therapy, it's like doesn't get the same. And it's like always so miraculous, and it's always such great cases to actually see and follow for them to come back in, and they're talking, and then now they're back at school, or some of them are even participating in their sport. It's like downright miraculous, right? So what underlies that sort of miraculous nature of that recovery? I think that is the fact that their neuroplasticity is at a heightened level because their brain is still developing, right?
Yeah, some sort of still in the critical period.
Right.
But the good news, just because I'm not in that age range anymore, is that even the adult human brain is still plastic. So, and we can definitely say that because we see with the manipulation we do, we see changes and improvement.
Right.
So that's the good news. But it is definitely true that a young brain will respond differently to therapy, to recovery, and anything and so forth. But this also points out to the fact that you really have to individualize your therapy, your treatment.
Right.
So this is true, obviously, for medication. So you will change the dose based on, height and weight and whatever. Same with brain stimulation. You might have to really titrate and change the amount of dosage and brain stimulation that you delivered just based on the patient response. So, I can also add that there are things that still surprise me quite a bit, which is sometimes you see a patient with a very big lesion and you think, this is going to be a disaster.
Yeah, it's going to be devastating.
Devastating.
Yeah.
And then the patient come in and you're like, what?
Right. Right.
Patient is doing pretty well.
Right, right.
So, they might have some motor impairments, of course, but then cognitively, they're not that bad.
Yeah.
And then you see little lesions, and then patients, I'm not saying devastated, but definitely doing pretty bad.
Right.
So it's a bit of unpredictable there. So it really depends on the genetics and on the baseline of what you're working with. So, and this is probably true both in the young population as well as in the elderly population.
I remember I saw this one kid that he was skateboarding down this huge hill in his neighborhood, and of course wasn't wearing a helmet, fell off the skateboard head first into a parked car, right? Completely out of it, went to the hospital, had to be intubated because his traumatic brain injury was so bad. There's bleeding all over the brain, bruising all over the brain. And I saw him 6 months later, and he was just like, "I'm fine. I'm back at school. I just have some headaches every now and then." I'm just like, "Oh my gosh!"
First of all, thank God.
But you can't explain that, because I've had other patients his same age come in, and it's just it's completely different scenario, right?
Yeah,
where they're having trouble speaking, it's just...
Yeah, it's amazing how some brain have this amazing resilience and some
Right.
others don't,
Right.
which is obviously true in degenerative disorders, right?
Right.
You see, when Alzheimer's hits you, that's it, right? But you can definitely tell when there is a patient that has, high level of education and well-read and everything, that really is somehow resisting to it.
Yeah.
Whereas, and then of course there will be variability there too.
Right, right.
But this is another big field where we're trying to use non-invasive brain stimulation to see whether it can be alternative therapy treatment to support or delay degeneration in Alzheimer's disease or frontotemporal dementia.
Yeah.
These are other two trials I'm involved too.
Oh, you're involved in trials?
I am.
Yeah. So, because I've seen...
Boston.
In Boston, yeah. I've seen the TDCS used to enhance cognition in, I believe it was dementia patients.
Yeah, I mean, I don't think that was a very strong study, but yes, there are some studies out there. And considering that as of now, medications are not really showing great data.
Medications suck.
Okay.
For this,
say
for,
that.
no, for the dementia, of course. We have, the current. I'm sure you know about this controversy with the recent FDA approval of a medication for Alzheimer's disease.
Yeah, based in Boston.
Right. So Alzheimer's, it's basically you have accumulation of this protein. All these medications have been tested that decrease the burden of that protein, right? But they never translate to clinical benefit. Right.
Yeah. So the amazing, impressive thing is that this medication is effectively reducing plaques in the brain,
right?
But the cognitive behavior is just
the same. Yeah.
So it's okay, great. I have a clean brain, but
nothing else to show for it. Right.
Exactly.
Yeah, I know.
So and so we have these two clinical trials where we are delivering TACS to see whether we can help clean some of these plaques, and then we're also measuring behavior and all sorts of measurements
so
you can do before and afterwards.
You found that these can actually clean the plaques?
So this is based on physiological data. So
Okay.
there is a group at MIT that showed that if you in mice, if you do this light treatment with gamma light, the model mouse of Alzheimer's disease reduces the plaques in the brain. But, the behavior you measure in a mouse is obviously very different from what you can measure in humans. And so based on those premises, and we made the hypothesis, I did not make that hypothesis. I'm a collaborator on the grant.
Right.
But my collaborator made this hypothesis that maybe if you can deliver gamma stimulation in Alzheimer's patients, you might be able to help slow the disease, at least. That would be nice.
Gamma light?
No, this is TACS, Transcranial Alternative Current Stimulation in the gamma frequency.
Oh, okay, sorry.
Okay,
yeah.
so with the electrodes on the head, so still direct current stimulation, but with a specific frequency, of stimulation. And so they're being stimulated while at rest for a few weeks, but then they measure all sorts of parameters before and afterwards. They have PET scans, fMRI, and all sorts of behavioral and cognitive tasks that are done before and after the training. This is an ongoing research, so don't ask me for results.
I was just about to ask you all about the results. That's what I was waiting for.
They seem a little promising, but we don't know yet. So it's too early to say. But also COVID didn't help because during pandemic time, those of us working in brain stimulation, so we really cannot test subjects and patients online. So we need to have them in person.
Right.
We had to shut everything down for a couple of years. So it's been really tough. But that slowed down things everywhere. I mean, in Italy, here, everywhere.
Yeah. Are you ready to move past the brain injury state and talk about the normalized performance enhancing state? Or unless there's anything else that you want to talk about regarding injury states?
No, I think we can move over to the, how to make a superhuman.
How to make a superhuman? That's the reason I have you here.
Okay.
I'm actually Lex Luthor, and I want to become a superhuman.
I'm afraid you're out of luck.